All right. So, doctor of physical therapy, and tell us a little bit about what is the pelvic floor? Give us a pelvic floor 101.
Yes. I yes, I do that a lot. So pretty much what I kind of start with is when we're thinking about pelvic floor, think of it as like this bottom of your core. So I always want to point out we have like our diaphragm, which sits in our rib cage. We have like our lumbar paraspinals. We have this deep transverse abdominis core muscle. And then at the very bottom is our pelvic floor, which people are like, oh, I didn't know I had that. I've had plenty of people tell me I didn't even know I owned one of those. So yes, everyone has one, males and females. Um, the function of the pelvic floor, so there's five functions that we mainly talk about. The ones I point out the most is it's postural. So if we're like standing, sitting, breathing, lifting, doing really anything, that muscle has to kick on and give us our support throughout the whole entire movement. And so a lot of times when people come in with certain dysfunctions, it's partly because that pelvic floor just isn't giving a lot of good support. Um, and so that's one thing I would definitely say perimenopause that we definitely highlight on. The other thing is that anything that enters or exits pelvic floor, or enters or exits our body is kind of going through that pelvic floor. So if there's not good mobility or if there's a lot of tension, um, we're going to start to form some dysfunction. So some people will have complaints of constipation, and it can be a mix of diet, fluids, but also a lot of times it is just like I just have a lot of pelvic floor tension that's limiting on that like rectal canal. I'm gonna show you guys this. I have images, but I also have this pelvic model. So this
Perfect.
is the deepest layer. This is the female model. So right here is where like the vaginal canal will pass through, and then we'll have our urethra pass through, and then this is where our rectal canal will go. Um, The reason I love pointing out this is because the deep pelvic floor is really only this small kind of area here. And then we have all these other muscles, and not even all of them are on here, all these other muscles that we actually assess and palpate the same way. And they're just hip muscles. So we have our obturator internus, we have our piriformis behind it, our coccygeus, all of which don't necessarily serve the same pelvic floor function, but they do help with support. They have fascial connections. They're definitely going to contribute to dysfunctions. And that's when we start to have people who are like, oh, I have leakage, but I also have like back pain or hip pain or something along the lines of that. And a lot of time it's just the correlation between those areas.
Right.
Um, but that's the deep pelvic floor. That's the third deepest layer. We call it like the diaphragm layer. We have a middle layer, which is my favorite because I love treating urinary leakage, especially like stress urinary incontinence. And so the sphincter muscle,
Let me
yeah,
stop you for a second. So, when
yeah,
you're saying stress urinary incontinence, you're talking about when we sneeze or cough or something like that, right?
yeah, pretty
Yeah.
much. And I sum it to like anytime we have an increase of pressure that's going to be put on the bladder and it makes you leak, it's kind of stress urinary incontinence.
Yeah.
So I don't even always limit it just to like coughing, sneezing. Sometimes people are like, oh, when I'm lifting heavy, especially during this phase, like lifting heavy weights is really important because of the change in estrogen and loss of that stimulus. But they'll be like, well, I'm having a lot of leakage, or I just stand up and sometimes I have leakage. But I assess, I'm like, is it the standing or is it what's going on pressure management wise with your abdominal cavity when you stand? If you're standing flawlessly and you're having leakage, maybe it's not stress. But if you're kind of doing like a type of movement, it's probably just the pressure being put on the bladder.
Yeah.
Um, but yes, so that's what I typically see. But there's this sphincter, and I don't know if I can share my screen because this is kind of easier shown in a picture. Um, so let me see if I can pull it up and I can show you guys.
Yeah, take your time. And, you know, just anybody on the call, if you want to jump in, obviously this is not private today. So if you're wanting to jump in with a specific question or concern that you have and you're willing to share that, just go ahead and
Yeah.
unmute. It's very casual. If you have a question about something that Dr. Corrie is talking about, you don't quite understand she is definitely speaking in
Different language.
different language. Yeah. So just jump in and holler if you've got a question.
Yes.
For
I
sure.
will say, like in our treatments, it's normally like your first visit is like 30 minutes of just talking about pelvic floor because it's a lot and it's
Yeah.
very confusing. I was very overwhelmed when I first started training because I was trained underneath Marie and she's a wealth of knowledge. And like my first day, I was like, I had like a book of notes and I was like, okay, so this is a lot. There is a lot to it. So I
Yeah,
totally get it. It's natural for me now, but it is definitely not natural for um most.
for
Okay, I
sure.
think this might.
And just for anybody, while you're doing that, for anybody who doesn't know, Dr. Corey works under Dr. Marie Warner from Warner Physical Therapy here in Fort Worth. They have what, three or four clinics here in the Metroplex?
We have five.
Five. Oh my gosh. Anyway, the pelvic floor physical therapy practice in the Metroplex. I mean, they are absolutely phenomenal.
Yes, I was very lucky with, I'm not gonna lie. It kind of just landed in my lap. And so I'm very fortunate.
Work
If
hard.
this doesn't pull up, because I think it might be I'm using my work laptop and there might be a privacy setting. Either way,
That's
I'm
okay.
gonna show you guys because I have a binder. So if you guys can bear with the binder, I can show you that way. Um, so I'm gonna show this picture. It's slightly inaccurate to what I'm pointing out, but you get the gist of what's going on. So right up here is that sphincter that I was talking about. Again, not 100% accurate. It's a little higher, but we have an external urethral sphincter. Don't need to remember that name. All I need you to remember is that there is an external and there's an internal. External is striated. Striated means we can control it.
Right.
Internal, smooth, can't control it. So can't really do much. Actually, a lot of the males that I'll see for urinary incontinence, they're coming in after a prostatectomy and that internal sphincter kind of gets removed.
Yeah.
And so part of it is just now that external just has to compensate.
Hmm.
Good thing about being able to control a muscle is you can train it. So a lot of times it's a matter of with those instances of like coughing, sneezing, standing up, heavy lifting, we want to strengthen this sphincter that's compressing the urethra so that no urine escapes. And then we also want to manage pressure. So, like, what can I do to decrease how much pressure is being put on my bladder when I do a particular movement? Can I increase the strength around the urethra during a cough before I perform or sneeze, if you can expect it, to help decrease the amount of leakage? And so that's when, in those instances, I always talk about breathing. I think with every single patient that comes in for pelvic floor, because it's a pretty big deal. But especially in those instances, it's about, okay, don't brace, but breathe out on like the hardest part of a movement. And we just work through, okay, what are some things you're struggling with and how can we breathe essentially through it? On top of, on the side, you're going to be doing some strengthening for that sphincter specifically.
So how would one be experiencing that dysfunction? Like, let's say so you've got the voluntary sphincter, which is the external
Mhm.
sphincter that we can
Mhm.
voluntarily control.
Yeah.
And then the other sphincter, which is involuntary on the inside that we cannot control. So let's say we've lost tone in that involuntary sphincter. And I know I'm not using the correct words,
It
but
works.
so that external sphincter has to compensate.
Mhm.
And would that feel like a sense of urgency, or would that be like all of a sudden, like I was trying to hold my urine in, but that I absolutely couldn't hold it in any longer? Like what's the symptom that people are
Yeah.
experiencing with that?
So there is normally a lot of times, one thing that is pretty common on top of that is, so yeah, they'll have drops, and that's what they'll notice is it's just leakage. You don't feel it coming on, but you do eventually get into this habit of, I know every time I do this, I leak. So they do kind of start to expect it, but initially not something that they would have been able to control. And then, yeah, they can't control it even though they know it's coming. But another part I assess is, okay, how many times are you going to the bathroom a day? And then when you're done emptying, do you actually feel like you emptied everything? Or do you feel like maybe you're having like residual urine still in your bladder that needs to
Right.
empty? Yeah, when you're standing up from the toilet and that's what causes you to leak after you just went to the bathroom, you're
Right.
gonna have leakage. So that's another thing that I normally look to is like, okay, well, what does your bladder health even look like in general? Like, how many times are you going?
Right. And that could be a lot of things, right? Like prolapse could be causing that. So there could be the sphincter. So there's a lot of different things that could be contributing, which is why it's so important to go to a physiotherapist and
Yes.
figure out exactly what's going on.
Yeah.
So okay, so incontinence is definitely an issue that a lot of people deal with, um, heading into menopause.
Mhm.
We also see in my practice, we have constipation,
Mhm.
which can be a big pelvic floor.
Yes.
Pelvic floor issues can contribute to
Yeah.
that. So one of the things that is interesting when you start to get into pelvic floor work is this idea of triggers. And it could be like with incontinence, it could be beverages like caffeine can trigger you to urinate more often. Food triggers can cause you to also urinate more often. And, as probably most of you know, that these food triggers can also cause constipation. However, I have seen clients who have done tons of work on their diet, but they still have the issue of constipation because there's some kind of physical
Mhm.
issue, usually in the pelvic floor.
Yes. And that's why I think, because we've talked before also, like I am always like, if someone comes in with constipation, a lot of it is like, okay, well, what can we do? Food, water, like, can you see someone else while we go through this? But then there's also, it's kind of maybe chicken or egg situation where I'm like, either you had constipation because of your diet or your dehydration or whatever,
Yeah.
or just inflammation, and that led to pelvic floor tension, or you had pelvic floor tension due to maybe stress, and it's led to this history of constipation. So at the end of the day, it doesn't matter too much because they need to be eating what's good for their bowel and GI health, drinking plenty of water, and then making sure they don't have pelvic floor tension. This actually, I pulled this out when you were saying that. This, I think, shows a good representation. This is
Yes.
our squatty potty, and we're very pro squatty potty in our office, but we have one in every single bathroom. Um, but this is a good representation of what it looks like to have pelvic floor tension or pulling around the rectum and then or rectal canal, and then what it looks like for it to be relaxed. So if we're having a pulling, we're having a narrowing for emptying. So that's where people are coming in. And especially because I'll have people who are like, I have constipation and the stools are softer. They're like, but they're pebbles. They're small or they're skinnier. And a lot of times I'm like, that's probably just because of the narrowing of that canal, but it's not in an optimal position for you to completely empty. So yes, breaking down like some of the pelvic floor tension, and then also I always look at, okay, what is your hip flexor tension? What are your abdominals doing and what's your abdominal strength? And then how's your diaphragmatic breathing? Three muscles kick on when we poop and one turns off. Your pelvic floor should not be working. It doesn't need to do anything but relax and rest and digest.
Yeah.
So, but the three muscles that do need to put in work is the diaphragm, abdominals, and then the hip flexors actually. So,
I think that is fascinating when you're
yeah.
talking about that muscle because the natural human posture for elimination is not sitting on a toilet. It's
Mhm.
squatting,
Yes.
like squatting on the ground, like you're camping.
Mhm.
So if you think of traditional cultures that, they rest in a squatted position, those hip flexors are very open, but
Mhm.
they can hold that squat for a long time. They can rest in that squat. And when you're in that squat, it releases that rubber band tension from that rectum. What is that muscle or that?
This is like the levator ani group that's
Yeah,
around
yeah.
it. Puborectalis. Yeah,
Okay. So thank you. I'm not good with structure.
that's okay.
So that's our natural position. And so a lot of times we can help people with constipation just by getting them in a more natural position to eliminate, which is fascinating. It takes
Yes.
the tension off. So I have a couple of questions that have come in. So we're trying to keep things anonymous. So I
Totally.
had some people write in some questions early. And somebody was asking about pain with sex.
Yes.
Um, what is going on?
Yeah, there's a lot. So, I was like, when I was like thinking of things, because I think on your email, you're like, what three things do you look for, like pelvic floor dysfunction? And I was like, I'm just going to put pain in general because there are three layers to pelvic floor. And so there can be a lot of different muscles or layers contributing to pain. So it depends. I'll start by screening. Okay. Is it one, does lubricant decrease the pain? If people say, no, not really, like I've tried it, like maybe it helps it a little bit, but not much, then that normally is okay. You have the tension of the pelvic floor, and lube isn't going to help with tension. Lube just helps with vaginal dryness and discomfort.
Right.
Um, so then I'm kind of working through, okay, you probably have some tension. And then it's a matter of, okay, where do you feel the pain? So some people feel it more at like the opening or what we call the introitus. So that's like the opening of the vaginal canal. Or people will feel it more deep internal. Some people feel they're like, it feels like almost like pelvic, not pelvic cramps, but they're like, it feels like my period cramps sometimes.
Yes.
But they're like, it's like in the front of my hips. They're like, that's not pelvic floor. And I'm like, well, it radiates around and it also spreads. It's kind of free game. Pelvic floor kind of radiates to a lot of spots.
Yeah.
So it depends on where their pain and tension is. Most likely, so thinking of perimenopause phase, what happens because of the changes in estrogen, um, and not even just the drop of it, but the fluctuations in the ratios and balance.
Yeah.
The two areas that I find, and it's pretty if it's a 50-50 split, if not, they have both, is they have a lot of pain at the opening, and that's because that vestibule, and that, I probably have another picture somewhere in here. Um, all those muscles start to have some weakness, atrophy, stiffness, poor lubrication, dryness, the whole deal. It's super irritated. I'll even have people who are like, I have pain when I like wipe after using the restroom. And it's just because that urethra tissue, the vestibule, the vulva, it's just irritated. And so in that instance, we can do like trigger point release stretches to relax it. But I always tell people, okay, what topical thing can you put on this area to help with urethra help and vulvar health? And it doesn't have to be hormone replacement therapy. There's a lot of options as far as cream goes to kind of help stimulate that. And a lot of times that alone, if people just have the pain at the opening, they start doing, like, we have a cream that we'll recommend to people, and like I said, it's over the counter, and it's just like DHEA, and that alone, they're like, oh yeah, no, it's a lot better. They're like, I have more stimulation, I have more pleasure, I don't have the dryness, and I don't have the pain.
Yeah.
And then for deep pelvic floor, it's a matter of same thing. Like if there's a lot of tension, you just need to do a lot of stretches, exercises, and I can go over all that stuff too, to decrease all the tension and start relaxing any tension that builds up because it's pretty common because there's a lot of fascia, ligaments, and obviously it's a muscle group. So with the changes in hormones, there's going to be stiffening that occurs. So stretching is going to be like the pelvic floor's best friend in that instance for pain.
Yeah, that's awesome. So if someone were going to come to physical therapy specifically for that issue, I don't know, let's say it's the deep pelvic floor issue. Is the physical therapy itself painful?
Yes. It's a temporary pain, I would say. It's a trigger point release. So, it's in a lot of time people are like, that's my pain. You just replicated it. They're like, that's crazy. Even when they're like, oh no, my pain is like in my abdomen, so I don't think it's pelvic floor. And I get on a muscle and they're like, that is shooting to my abdomen. That is exactly what I've been feeling. Um, so it's temporary pain, but it's an intentional trigger point release versus with intercourse, there's no intention behind that. So you go on each of the muscles and you just apply pressure and
Mhm.
you release it. You get blood flow to the area, so it has good, essentially you need good blood flow for everything so you can have good tissue functioning. Um, so good blood flow to the area, and then it also helps decrease the tension and help it start to relax
Yeah.
so that when you go to have intercourse later, it's less painful. So it's like a pain that's now, but if anything, all you'll have is kind of the soreness afterwards.
Kind of sounds like it's kind of like ART, or I don't know if anyone's ever had active release technique done at a chiropractor. It's like super pain. It's like it hurts really good, you know, because you have pain in that area and you want it to go away. So anyway, it sounds like ART to me.
Yeah. Yeah. It is pretty much just like release it. And then I have people do the diaphragmatic breathing. So not only is that helping with the movement of pelvic floor so we can get some extra lengthening, but it helps calm your nervous system down. So depending on why your tension has developed, if it is anything about a stress response, which a lot of times, uh,
Right.
especially in younger women that come in, a lot of times it is like a stress response. Um, the diaphragmatic breathing helps relax a lot. And then I'll tell people that like I'm like, do some prep before you know you're gonna go into intercourse. Do those stretches, do your breathing. If you can do like perineal stretching or something to kind of prepare. So then you won't have any tension. Because obviously if it's painful, you're gonna tense up. And so that's
Yeah,
just gonna contribute to it more.
absolutely. Well, since you're talking about it, well, before I kind of just railroad down the track here with another question, does anybody want to unmute and ask a question? Has anything popped up for anyone? Okay. Um, let's see. So my next thing was, since you're talking about the diaphragmatic breathing, I think if you're willing to give people a free lesson, and it would be something that they can actually do today, because we all have a breath.
Mhm.
Would you be willing to sort of walk us through what that breathing looks like and how we can do that?
Yes. It is super easy once you practice. I do have a few people, they're not belly breathers, and they're like, this is so hard to coordinate. But I'm gonna push this back a little bit and then I'm gonna put it on me, and I might even have to lower the table. But I think by this way you can see me. So I always have people start one hand on your chest, one hand kind of like right where your rib cage begins on your belly. All you're doing is you're breathing in through your nose, and when you breathe in, your belly expands. So, and then out through your mouth, and then your belly sinks. The key, and I'll even have people do it in the mirror, is that you don't want your chest to rise with it because then you're not letting your diaphragm expand as much. And so I'll have people either do this for like go for 30 seconds, or I'm like, even just doing 5 breaths at a time throughout the day will be super beneficial. So big breath in, and then it's also good because I'll have people start doing this with their stretches. So if we're thinking of, and I'll give you guys another stretch. Okay. So if we're thinking of deep squat stretch in that optimal position for pelvic floor to relax. And I don't know if this will, we'll put it here. Okay. Um, I always tell people do it supported so you can relax your legs and everything as much as you can. But I will have people do the diaphragmatic breathing while they're doing a deep squat. So I'm going to use the door handle for now. But you sit all the way down, you kind of are supported, and then I'll do a belly breath. So, and then as you do the breathing, you typically can sink more into the stretch. Um, and I will say that is like the gold standard of most of the stretches for pelvic floor. Like I think that's the most optimal pelvic floor relaxation stretch.
Yeah, kind of like the foundation of, right? Well, I think you guys are awesome. I have some more questions, but I just want to say, in my humble opinion, I feel that the pelvic floor physical therapists specifically, I love my physical therapists, but the pelvic floor specifically, you guys are like the functional medicine doctors of physical therapy, right? Because there's so much when we're talking about functional medicine, we're talking about getting at the root cause. How does the body function versus just medicating a symptom? And so what they're doing is really getting, I mean, that pelvic floor is so integral to every other, I mean, it's connected to so many things. It's so integral to your structure. And anyway, so I just think that's awesome. Thanks for showing us that, Corrie.
No, I agree. I actually always joke because when I was in PT school, we started with like knee and ankle. And
Yeah.
I was, oh crap. I think I want to drop out of PT school. I don't think I like being a physical therapist. It just wasn't my thing. And then we got to low back pain and hip pain and like pretty much anything along the spine and the pelvis. And I was like, oh, okay, this is really
Yeah.
fascinating. But yeah, there's a lot of interplay because we have to also consider, okay, what is not just like your bowel movements, but what's going on throughout the colon, the intestines, what's going on from the liver all the way down to the processing through the kidneys, all that sort of stuff. So we have to kind of take in consideration all that stuff.
Yeah, absolutely. So there's so many things that can go wrong with our pelvic floor health as we age, as we have so much that goes on down there, especially as women. I mean, even men do too, but we're having babies. We are, anyway, we're on birth control, we're on all kinds of stuff that's
Yeah.
affecting our pelvic floor health. So I recommend everybody go annually
Mhm.
just to have a checkup. You might
I
not be
am
having a problem,
right.
but just go and check up and make sure that, you're not starting a prolapse or something. Because what happens a lot is that we kind of think that some of these dysfunctions are just part of aging, like a little bit of leakage, right?
Yeah.
Yeah, go ahead, Elaine.
So with, I mean, and I maybe this is changing in Texas, but I think for a while, like I had sprained an ankle and I just wanted to go get some PT exercises, and they were like, "Oh, you've got to get a referral."
Yeah.
I'm like, "Why do I need a referral? I know I sprained my ankle, and I know I just need PT." And so, do you have to have a referral for that kind of PT too?
Yes.
Yes. However, we have a 10-day window. So, like you can come for 10 days. Unless you're Medicare, and then I think that's a little different. I know insurance plans are differently, but we're a cash pay practice, so you can we can see you for 10 days. If you have your WCS, which is your women's specialty, you get like an extra 4 days. So you get 14 days. So I think Marie, our owner, gets a 14-day pass. But that at least gives you enough time where you're like, okay, because some people truly like if it's a matter of like, oh, I just want to like check and see what's going on with my pelvic floor, get one session in and then kind of treat it like a massage essentially as far as like massage for pelvic floor, but like what exercises can I do? Maybe get some trigger point release, get some education on what you can do to prevent issues. But you can do that for one visit. And then it would just be a matter of if you're like, oh, I think I need to keep coming for continual visits for the next few weeks, then you'd have to get a referral. But we try not to make that an issue as far as blocking people from, at least, because no, 100%. I have plenty of people who come in and they're either pre-op something, or they just are like, I don't know, my friends were talking about it and I kind of just wanted to check it out. So, and I think that's awesome. It's super preventative and they leave with a wealth of knowledge. I always send people a big email of like, this is all I talked about. Take it and run with it. And then, yeah, if you don't need a follow-up session, I think that's fantastic. That's kind of the goal, is that people, unfortunately, I would hope that no one needs me forever, but
Yeah, the goal is to work yourself out of a client, right?
yeah,
Same with me.
yeah.
Yeah. Well, okay, so I'm going to be really vulnerable because I just had a surgery this week
Mhm.
for fibroid removal.
Mhm.
And anyway, it's a long story about what happened in the operating room, but I am really um, tender. I feel like I had a baby without all of the physical exertion of having the baby. So, what would you recommend post-op for just, getting that
Yeah.
back into working order?
Where were the incisions?
It was vaginal, so there were no incisions. There were just
Okay,
um,
perfect.
uterine fibroids.
Typically, sometimes they'll have like precautions after a while for like stretching, depending on what they do. But you can normally go in. So the deep squat would be great to start decreasing tension. I actually recommend this a lot, and it's not even just because people are like, it might not be their exact issue, but thinking of what can I do to get blood flow to this region. And so that's why I sometimes will just recommend like self-perineal stretching. And so it's not like you're doing a full-on trigger point release in the pelvic floor, but you're at least applying a stretch, which is allowing blood flow to rush into the area, so then it won't be as tender. And then those deep squats, the diaphragmatic breathing would be super helpful. And then depending on if it's just along like, because it could be just along like vaginal canal, it could be deep pelvic floor that's tensing up. It could be hip muscles that are referring. And so then there would also be certain like hip stretches that I would recommend for people who like a piriformis stretch or an obturator stretch, just globally decreasing tension. And then in those instances, I always encourage people, okay, try not to sit as much, or if you do, just make sure like you have opportunities of standing, opportunities of walking, just getting general blood flow to the area. So that can heal and you won't develop a bunch of tension down the road.
Yeah.
It just eases
That's
up.
helpful. Yeah, because that's the issue, right? Because when there's an injury, um, there tends to be some seizing up that happens in the musculature so that it can kind of work as a cast to heal it, right?
Yeah.
Yeah,
And there's also, I mean, there's weakness that develops in surgery. I mean, most surgeries, they find that after a surgery, you have like 50% of the strength that you started with, depending on what their approach is. Obviously, not all surgeries, but so general weakness means muscles are like, okay, well, we do have to do this job still of supporting, so we're just gonna kind of tense up. And so that can start to develop like trigger points and tension. So yeah, I would recommend like the stretching would help with decreasing all the tension and trigger points that might develop.
that's good. That's really good to know. Thank you.
Yeah, of course.
Well, any questions popping up for anyone? We're just kind of barreling through a conversation here. I had a client, this is a while ago, who she well, this is going back to the incontinence issue, but she felt like she normally could, like hold her urine, if it like let's say she was saying she had to go to the bathroom really bad. Well, normally she could hold it. And she said one day it was just like it just came out. Like all of it. And she was in the car and she was trying to hold it, but she just couldn't anymore. Do you feel like that was that external sphincter trying to hold on to everything, or
It was probably so another thing I always point out. Some people, and that's why I always tell people I have them do a stop flow test.
yeah.
And so you go to the bathroom, you empty your bladder for 5 seconds, and then you try to stop your flow. If you can stop it immediately, I don't think the sphincter is an issue. And I have a differential that I go through for the other muscles that might be contributing. Um, so, but if it doesn't stop, then yeah, it means the sphincteric muscle's most likely impaired. But I also always point out, so if that's the sphincter muscle, the deep pelvic floor muscle literally sit like right behind it. So it's helping it. It should have good strength as well. They kind of work together. You can isolate it a little bit, but they work together. So it could sometimes it's just a matter of the deep pelvic floor not being able to add enough assistance or compression around that urethra. And that can be because of just general weakness, like maybe it's just not strong enough to contract. Or if there's a lot of tension in pelvic floor, it's also not going to contract. It's going to stay in like this tense ball and it's not going to be mobile enough to assist in that. Um, and then another thing, which I think is so interesting. So our obturator internus, again, I just
Yeah.
think it is so fascinating. So I learn all this stuff. But there's a canal where our pudendal nerve runs through, and that nerve is what supplies your pelvic floor muscles, the sphincter muscle, which is wrapping around the urethra. Sometimes when people have leakage and they can stop their flow immediately, it's their hip muscle. That's what's causing their leakage is the obturator internus. And so they can do certain stretches for the obturator. And it actually helps with their leakage and it starts to decrease. And it was just because of the compression that that muscle was putting on the nerve. So it wasn't able to actually function.
Wow. Okay. That's fascinating. So I have a different
Okay.
a question that's coming to mind. Talk about a prolapse issue in the colon. What is it when women have um, they can't have a bowel movement because they're having a little prolapse that's going kind of into the vaginal wall?
Yeah. I have a picture for that too. I think prolapse is really easy. I think it's easier to digest when you see it on a picture, just because a lot
Yeah.
of people will come to me and they'll say, my doctor told me my bladder is falling out. And I was like, no,
Mhm.
no, it's in there. It's actually, it's in there. It's actually just leaning on the wall. So nothing is coming out unless you're having like a uterine prolapse and then that cervix is starting to descend. But rectocele, which is when the rectal wall, which is the back vaginal wall, so on the back side, that is when, yeah, that starts to prolapse and push into the vaginal wall. The reason that's an issue is because we need that to be upright so we can have a complete bowel movement. So sometimes, yeah, I'll have people come in who have what they assume is constipation because kind of the same reason, but they actually kind of just have a rectocele, which is a posterior vaginal wall prolapse. And so stool is getting backed up, and instead of emptying completely, it's kind of pushing and making kind of like a detour, essentially. Um, so it's not actually going straight out of the canal.
Elaine, go ahead.
Okay, sorry. You're showing all these great pictures, and so when I was having my babies and stuff, and whatever, they've always said that I have is it called a retroverted uterus or
Okay.
my uterus is, I don't know, somewhere where it's not supposed to be, I think, or tipped uterus, or I don't know what the word is, but are you showing, if you have pictures, like, I don't know what that means.
I don't have pictures of that necessarily, but I do have like kind of like a uterine prolapse as far as like its full descent is when it's so we have these when we have babies, we
Where
have
was
like
the uterus on that picture?
right here. So that's the uterus and then that's the cervix.
Yeah.
Okay, that's the uterus. I don't know why I was thinking that was the vaginal canal. So that's
Well,
below
it
that.
goes through, so we have our vaginal canal and then at the top of that canal is where that cervix kind of meets.
Okay.
The uterus is above that. When it's descending though, it's going to start to narrow a little bit. So that's why it can look a little different. But when we're pregnant and we're having all these other hormonal changes that occur, those ligaments start to lengthen and become lax, which is good. That's kind of the whole point, is that we have to prepare for birth. So sometimes people will have like the uterine prolapse or descent, and that's just because those ligaments that were once holding up that uterus aren't as tense anymore. I will tell people who come in pregnant, which I love when people come in when they're pregnant because they can really set themselves up. But I'll be like, lay flat for 3 to 4 weeks. You deserve the rest anyway. But also, if you're breastfeeding, your hormonal levels are going to be doing you a favor because you're going to have re-stiffening of some of those ligaments and tissue. So if you aren't standing and being active, you're actually helping those ligaments when you're laying down be in a more optimal position. But so that's my little tidbit that I always give like pregnant moms is I'm like, just rest. Your pelvic floor needs the rest actually after this.
Yeah.
But to answer your question, yes, that's the cervix. That's descending.
Hold that image up again, Corrie, because okay, so Elaine, we're looking at the middle set of images here. And so on the one on the left where it says rectocele underneath it,
Mm-hmm.
and it says anatomy without prolapse above it,
Mm-hmm.
that see how the uterus is tilted forward, and you can see the bottom of the uterus is sitting at the top of the vaginal canal. So I believe with the retroverted uterus, your
Yeah.
uterus is pointing the opposite direction. It's pointing back towards your colon.
Yes.
Yes.
This is the one without anatomy. Yes, it'd be going back here.
Yeah, there it is laying on top of the bladder. So, yeah. So it's just going the other direction.
Okay. So that's not a PT issue.
If it gives you symptoms, then you can come to PT. But if it doesn't give you symptoms, then yeah.
Well, there you go. That's a really good question, Elaine. The the prolapse issue always just terrified me. I remember in my late 20s, there was someone at church who had a prolapse and she had had some kind of surgery or whatever. And I was like, oh my God, I hope I never have a prolapse. And now I'm realizing how common it is and how many different kinds of prolapses there are, and that it's fixable too with
Yeah.
PT.
I was gonna say it can be functional. So a lot of people who have given birth before have some sort of descent. Like I said, that's kind of what happens. And it's functional. And so I'm always, yes, let's do what we can to support these vaginal walls. With maybe some strengthening, maybe if you have trigger points or a lot of tension that's developed, let's start there. But some people have minor prolapses and their symptoms are gone and it's functional, and that's great. For people who are still having pretty persistent symptoms, and I will say, more research has come out more now that pelvic floor is kind of more of a thing, about how effective strength training, doing your basic Kegels are for supporting a prolapse. And it's not as effective as, I'd want to like wave my flag and say it is, which is why there's a lot of other things that pelvic floor therapists tap into to kind of help support. So we do pessary fittings. And so for people who are like, I don't want to do the surgical route, but this is a pretty major prolapse, my symptoms are not changing, like doing a strength training isn't going to change the fascia of a vaginal wall or a ligament. They're not contractile, so you can't strengthen those. So if that's what's causing the prolapse, then I always think a pessary is a good option. And there's actually a really interesting study, and I wish I had it.
A pessary, for those who don't know, is a sort of like a prosthetic that you can put internally into the vaginal canal to help to support different areas. And the fitting, what they will do is make sure that it's just kind of pushing on all the right spots for your particular physiology. Do I have that right, Corrie?
Yeah. Yeah, there is, I mean, there is a lot of type of pessaries. So they have like a cube looking one. They have a ring. They have one that's just kind of a dish. There's like a donut. There's a blow up one. I don't know. There's a lot of them. But pretty much whichever one kind of is going to work best with your anatomy. And then the fitting is just a matter of like, okay, what size is comfortable but supports where we're at, and that's like the middle ground. So we don't want to use a pessary but that's too large and then it's just really uncomfortable, or a pessary that's too small where the prolapse is actually pushing the cube or ring or whatever out. And then depending on your type of prolapse, so like if you have uterine, we normally would use a dish more than like a ring in that instance because we wouldn't want that opening there. So, but yeah, they found there was a study that, and it wasn't a huge group. So I always tell people this, and I say, don't say this as like, this is not Bible. This is just a study that they did. But they found that women who wore this pessary, who had like stage 3 or 4 prolapse, and they wore a pessary for 24 consecutive months, so only taking out for cleanings, pap smears, all that sort of stuff, they actually had a reduction in their prolapse. And they were either, if they had 3, they went to either a 4 or stage 1, and then they were able to kind of independently go about life without the use of one anymore. It's not what it's advertised for. It's advertised for decreasing symptoms. So that's
Sure.
why I'm like, I don't tell people going into that, this is gonna reverse your prolapse, because that's kind of false advertising. But I do always mention this is going to help support those tissues. And so, especially if you're having some hormonal changes and things are starting to re-stiffen, I'm always like, optimize that. I mean, you might as well kind of benefit from that.
I know you need to go in a minute. Does anyone have a question before she hops off? I have one more question. Okay. This is about men.
Okay. Yeah.
I have a male client who is not on the call, who he's a young man and he has, let's see, he has a problem with the sensation of not feeling like his bladder is completely empty. He's done all kinds of different testing. Is this something that you see in men? And what do you?
So as far as like he goes to empty, but he doesn't feel like he completely did it. Empty
Right.
thing following. Okay. So that, yes, I really, anything with emptying the bladder, if there's a dysfunction, you can kind of assume pelvic floor is going to have some sort of impact on it. What can happen if like I said, what's most common that we see people in for is they have trigger points and tension. Even if it's something that they're like, no, I just need Kegels. I'm like, well, we'll see. And it normally is just, okay, there's some trigger points, there's tension. Let's start with stretches. With, in this instance, if there's not good blood flow, if there is nerve like entrapment, sometimes that doesn't present as pain. Sometimes that presents as maybe a sensory issue, or lack of urges. So if you can decrease the tension in those muscles, then a lot of times that sensation will start to come back because you have better blood flow and you have better nerve supply.
Mm-hmm. That's interesting. So it could be, so with the nerve entrapment, that's something that pelvic floor physical therapy could address.
If it's due to muscle tension, yeah.
Okay.
If someone came in and they had no muscle tension, no trigger points, their strength was awesome, like they were a 5-star, I would be like, oh, yeah, I would go somewhere else. But a lot of times that's what's going on, is that there's lack of one of those two things, and it's due to normally muscle tension. And a lot of the males, I would say, have muscle tension. And they don't know it. They hold a lot of their stress in their pelvic floor,
Yeah.
in their glutes and in their abdomen.
Yes.
So a lot of that kind of builds up, even though they're like, well, I didn't have a baby. Why did this happen? Well, there's a lot of other factors and a lot of other functions to pelvic floor, so it can still happen.
Yeah. Can you give us a quick little like 60-second 101 on diastasis recti?
Yeah, absolutely. One thing we check is not necessarily, I think there's a lot of fear around like how far is it separated? How much is the stretch? And yes, we look at the distance from point A to point B, but what's really most important when I'm assessing is what is the depth. So you have width and you have depth.
Yeah.
We want to get under control, but if when you do, so I'll have people lay flat, I have them just lift up their head, kind of do like a mini crunch.
Right.
If they have a lot of depth, that means they're not maintaining tension along that linea alba really well at all.
Mm-hmm.
So depending on the amount of separation and the amount of depth, then I have them do a transverse abdominis contraction. And so to kind of give you a brief explanation of what that is, we have a deep core muscle. I'll have people put their hands kind of like find your hip bones and then you fall off of them. And all you do is you kind of suck your belly in like you're putting on a tight pair of pants. You should feel abdominal muscle flutter underneath your fingers when you do that. That's your transverse abdominis. When you do that and then you do a crunch, if you have a decrease in depth, that means that transverse abdominis, another core muscle, actually is helping cinch and bring more tension and more stability in that region. So that's kind of what we go through. And then if there's not good activation, we want to work on activating TRA and seeing if that alone can help reduce some of that diastasis.
Okay. Thank you.
Yeah.
Wow. All right. Well, if anybody feels like they need a referral to Dr. Corrie over there at Warner, shoot me a message and I'll work on getting that referral. Corrie, thank you so much for being so generous with your time. You're awesome.
No, I love this. This part is easy. Like the talking about pelvic floor is probably the easiest part of my job. So I love doing it.
Yeah, it's great. Well, I just think you're awesome. So anyway, I know you need to go because you're on your lunch hour. So we'll let you go.
Thank
Thank
you
you
so much.
so much. Thank you guys. It was good seeing you all.
Thank you, Corrie. I'll talk to you soon.
Yeah.
All right. Well, everyone, thank you so much for being here. I appreciate y'all. Does anyone have any last thoughts or comments, questions, concerns? Just unmute. All right. Well, if not, I will see everybody Tuesday is when I will be back in the office. So I look forward to talking to y'all. Bye. Have a good weekend. Stay hydrated.